About a year ago, you couldn't watch the news without being inundated with reports of a massive epidemic in West Africa. This was the outbreak of the Ebola virus, which still continues to claim victims. The reports of this disease seemed to come and go in a matter of weeks, but very little was made clear as to how this virus was able to infect and kill so many people. The few cases of the virus that made it to our shores made national headlines and stirred widespread panic. In all the reporting, many questions were still left unanswered. Where did this disease come from? How has it infected so many people in West Africa, yet left first world countries basically unscathed? Why were international health organizations not able to contain this outbreak when it began, and instead let it grow to the magnitude it reached? How can this happen in today's highly advanced world, and how can we prevent a similar epidemic in the future? Ebola is not a rhinovirus like the ones we are used to dealing with in common diseases, such as the cold and flu. Instead, this is within the family of hemorrhagic fever viruses. It has the highest mortality rate of any disease within its family, of approximately 70 to 90%, compared with 15 to 50% for yellow fever, the next highest. Luckily, unlike other viruses in the family which are transmitted by animals and insects, such as mosquitoes, the Ebola virus can only be transmitted through direct contact between humans' bodily fluids. This means that Ebola cannot be caught by touching a railing or breathing infected air, as would be the case with a more contagious disease. This helps to keep infection rates lower and narrows the number of people who need to be put under observation. This lower number is helpful to healthcare workers because the Ebola incubation period can be up to 3 weeks. When an infected person does become symptomatic, the effects are brutal. The usual symptoms can be boiled down to flu-like symptoms of vomiting and diarrhea, a high fever, profuse bleeding from most bodily orifices, and complete bodily shock. Because no effective cures or vaccines have been proven to work, the only recommended treatment is taking care of the person's body and helping them to recover on their own. The patient is only contagious when they are symptomatic, so people who feel healthy cannot transmit Ebola. To truly understand the current outbreak of the virus, we must take a look at the origin of Ebola. The first documented case of Ebola occurred in 1976 in southern Sudan. Ebola receives its generic name from a river in the DRC, and the 4 discovered strains have been later named based on the locations of their outbreaks. The origin of Ebola is not known. However, it is believed that contact with wild animals leads to the infection in humans. Before 2014, there were only a few major outbreaks of Ebola within humans. The first 2 occurred within a couple months of each other in 1976, in Sudan and the DRC, or Zaire, respectively. These first instances each had relatively few infected persons, with the Sudan strain infecting 284, killing 53%, and the Zaire strain infecting 318, killing 88%. The 1989 outbreak of Ebola occurred in the United States when imported monkeys were discovered to contain a new strain. However, this outbreak led to no deaths. The fourth outbreak happened in 1994 in Côte d'Ivoire, beginning from a mistake in the dissection of a diseased monkey. A fifth, smaller outbreak occurred in 1995 in the DRC, but by this time the virus was understood well enough to keep the number of infected relatively low after early recognition of the disease. None of these outbreaks comes close to the number seen in the 2014 outbreak, which currently reports 15,216 confirmed infections and 11,298 confirmed deaths, not including those who have been infected and died without being tested to have Ebola. The current outbreak of Ebola is believed to have started back in December of 2013. However, the boy who appeared to be infected was never tested, so it is still unknown what specifically started the spread in humans. The disease spread rapidly between towns in the area, and the World Health Organization, or WHO, finally discovered and announced that this was an Ebola outbreak in March of 2014. By this time, the disease was only known to exist in Guinea where it had started. However, the virus was growing strong in Liberia and Sierra Leone. The underreporting of the infected led to a rapid spread through contact that managed to reach the capital cities of these countries. The large number of infected persons made this outbreak all but untraceable, unlike the previous outbreaks with very clear lines of transmission. This virus has also not affected West Africa before, as it normally manifests in the forests of Central Africa. This made it more difficult to diagnose and treat, as Ebola was unknown to the healthcare workers. By the time the outbreak was discovered and measures were put in place to prevent the spread of Ebola, the virus was already widespread. The unpreparedness of these countries was not simply a result of the lack of previous exposure to the virus, but also from a lack of infrastructure, slow international assistance, and an overall lack of resources to purchase medical supplies. The most effective way of containing and treating an outbreak of Ebola, as demonstrated in the past, is early recognition, tracing and observing contacts, and minimizing contact between an ill person and others. Since an asymptomatic person cannot pass on the disease, Those who must be isolated are easy to spot. Once they are detected, an infected person must be prevented from having direct contact with other humans. Since bodily fluid contact must occur for transmission, healthcare workers utilize barrier techniques to protect themselves. These devices include simple plastic gloves, face masks, goggles, and the hazmat suits we commonly see in the news. Bodies are also disposed of in plastic bags to prevent post-mortem spread of the virus. Proper hand washing and sterilization of healthcare centers, beds, and tools is also necessary. These type of control measures all have one thing in common: they are very expensive. As seen in the previous DRC outbreak, the majority of those infected by Ebola do so while trying to help those who are dying of the disease. When an outbreak is first noticed, many of the local healthcare workers are infected because they do not have the money to utilize barriers regularly. The lack of money in these areas also leads to a lack of disinfectant supplies, so tools and beds are not properly cleaned between uses. On top of this lack of basic medical supplies, these areas of West Africa have poor infrastructures. There are no well-known street names or systems of tracking people. This makes locating those who have been in contact with the infected much more difficult than it would be in a place like the United States. These countries also lack running water systems. The most effective way of preventing Ebola, like most other diseases, is proper hand washing. This is especially important for healthcare workers. If their hands cannot be washed between patients because there is no running water, the disease spreads faster. The long history of violence and destabilization that is observed in these West African countries prevented effective infrastructure from being created. However, neighboring countries like Nigeria did not have these problems. Nigeria, which is financially well off compared to the other countries in the region, only had 20 cases of Ebola during the entirety of the outbreak. This country has a much more advanced infrastructure and healthcare system, so preventing the spread was easier. The fear that spread through the U.S. in regards to the possibility of an outbreak behind our borders was unwarranted, but very much spurred on by the media. By publicly doubting the words of medical professionals and saying that they themselves are very worried about the disease, news programs instigated fear. This fear of the disease led to overly cautious actions, like the quarantine of a healthy U.S. worker who volunteered time in West Africa. Similar efforts were also made to close the borders of the U.S. from Ebola-ridden countries. The funds used to try and quarantine these countries would have been better spent attempting to end the outbreak at its roots. This fear-mongering also prevented travel of some healthcare volunteers to West Africa, as they would not be allowed back into the country without rigorous quarantine procedures. This perpetuated the outbreak's sustainability. The world was not ready for an outbreak of a disease like this, and it still seems to be unprepared for a future outbreak. The research into a vaccine for Ebola had not produced an effective cure or treatment by 2014, nearly 40 years after the discovery of the virus. Back in the early 2000s, DNA vaccination-like treatments were being developed, but not specifically for the Ebola virus. Work is still being done to create vaccines, and a few have gone on to human testing to see if they are safe, but not necessarily to see if they are effective. Other treatments, like blood therapies from blood of the survivors, have had some promising results, but no true cure is known. The WHO mobilizes to take care of these types of situations. However, a committee created after the 2009 H1N1 pandemic announced that the procedures of the WHO would be ineffective for dealing with sustained infections. This was seen in the reaction to the Ebola outbreak. The world was unprepared to effectively handle a sustained, global, rather than localized, outbreak of a deadly disease. The WHO also lacked the essential personnel and research facilities in these West African countries to fight Ebola. A shortage of funds for hiring and training employees, as well as maintaining the proper equipment to handle an outbreak, also led to the insufficient response. Less than half of the nations that the WHO operates in had the necessary locations and people to handle any sustained outbreaks. These problems were seen a few years earlier in the previously mentioned H1N1 outbreak. The virus was spread to over 70 countries, and over 1 million people in the U.S. were infected. Luckily, very few deaths were reported from this illness. A vaccine was developed and delivered to the U.S. population. However, it took nearly a year after the pandemic was noticed to begin dispersal. The time delay on making and distributing this vaccine is somewhat understandable, as the virus was never seen until the pandemic. But the 4-decade delay for the Ebola vaccine development shows the lack of research in this area. Many of these problems that led to the sustainability of the Ebola outbreak have not been taken care of and could still resurface in the future. Facilities around the globe are not up to date. There is not enough money saved up to effectively respond to a global epidemic, which would require the treatment of millions. The infrastructure of poorer countries will still remain a problem for tracing contacts of patients. Luckily, there are very few untreatable diseases that are both highly contagious and deadly, so a worldwide catastrophe is unlikely. But Another outbreak of any disease could be difficult to contain. We should not fear an outbreak, but more needs to be done so that we are prepared for the next one.